Hi guys, welcome back. The topic I'm going to explain to you now is crystal arthropathy, and the first one that we're going to talk about here is acute gout. You are aware of the fact that in this particular disease, we would be having swelling of the big toe, and the technical term that we use for that is either podologia or podagra. Do remember the fact that in most rheumatological disorders, the question or case given to you in the exam will always begin with a young female in reproductive age group. But in this particular case, you will notice the fact that most of the MCQs will begin by describing a middle-aged male. Well, you can also remember from the previous discussions that I've had with you that when it comes to rheumatological disorders, it is ankylosing spondylitis, which is relatively more common in a younger male. And for middle-aged men, the incidence of acute gout would be relatively on the higher side. And I'll explain the reasons for that as we progress. In fact, in some questions, he might deliberately begin by describing a post-menopausal female as well. Now, he will say that this lady has been diagnosed as having hypertension by her general physician and has been started on diuretics. During the hypertension discussion, I had specially pointed out that after 55 years of age, the current protocol is to give calcium channel blockers. Now, what is the problem with diuretics? Why are thiazides not so famous, or I would say CCBs are having more popularity among physicians for prescription as compared to diuretics? You are familiar that long-term thiazide usage can actually contribute to development of glucose intolerance. So those who are diabetic, because when we talk about old age people, diabetes incidence will always be higher. India is anyway hotspot for diabetes. So the problem is if you give thiazides to a person who's also a diabetic, then there's a distinct possibility that is HbA1c values will turn out to be higher than what they actually are because this drug contributes to impaired glucose tolerance. The second biggest problem is that this drug can contribute to impaired lipid profile as well. So the incidence of coronary artery disease can also be affected. See, in old age, already there are concomitant medical disorders, so I don't want to add on to the problem. So the problem in this lady is today that not only she is going to be having the aspects that I said, that is impaired glucose tolerance, deranged lipid profile, but diuretics can even trigger a acute attack presentation of gout. You see, it can contribute to increase in uric acid levels. So please remember the fact that ideally in old age, as I've highlighted in the hypertension topic, the patients of hypertension should be on calcium channel blockers. But in this case, let me say following the older protocol, the physician has started her on diuretics and therefore acute gout attack was triggered. I'm not saying the fact that don't ever use thiazides. Yes, you use it as a backup. Like, you have given CCB, there's no improvement in blood pressure control in an old patient, then you can add ACE inhibitors. If there's no improvement, then you add diuretics. So they are the last resort and not a primary resort. Now, once I've clarified that, I want to tell that in this particular condition, the swelling of the first metatarsophalangeal joint, which is characteristically involved, can be so bad that it can actually look like cellulitis. I mean, a casual look would be a patient woke up with this pain at the base of the big toe, and he says that I thought there was some kind of an infection. In fact, first impression that you get from listening to the complaints, because this swelling is going to be red, it's going to be tender, it's going to be warm to touch, so you might get an impression that this is an infection. But as I highlighted, this is the inflammatory process which is happening here. The term that is used in lots of questions and therefore is hard to miss is either the term podologia, or he can also use the word podagra. As such, clinically speaking, there is a high possibility that, clinically, it's unlikely to get this wrong. It is the investigation part that he'll trick you with, and I'll tell you what will be the thought process of the examiner in a while, so that you can obviously get out of the mess that the examiner will try to create for you. But I am saying that clinically it is impossible to get this question wrong from the presentation, which is very easy to identify. Now, don't be under impression that it is only the tarsal joints which are involved in this condition. There could be a possibility, like in this image also, you can notice that there is some amount of swelling related to the ankle joint. So even ankle joint swelling and knee joint swelling may be present. In fact, in some cases on the knee joint or around the knee joint on the extensor aspect, there could even be soft tissue deposition of uric acid or monosodium urate. So another presentation of this disease that you will always read is tophi. Tophi can be present on the extensor aspects. It could be present with respect to ankle joint. It could be related to the shin. It could be just related to the knee joint just below the patella. Or for that matter of fact, he could also describe tophi in the hands of a person. He could describe tophi even in the earlobes of the patient. And this is important because tophi tell you that this guy is actually having an acute and chronic presentation. because already the uric acid would be substantially high to get deposited in the tissues. And then there was a flare up that occurred due to various reasons that we will study. But lots of time, tophi could be present in the hand and in the earlobe also. In fact, here I want to make a very interesting point. I'll just zoom into this image. You will notice that this is a hand of a old man or a woman. Let me say she's grandmother age, something like 70 years of age. You can notice the deformities in the fingers. She's not rheumatoid arthritis. You can't see any swan neck. You cannot see any boutonnieres. You cannot see any Z-line deformity. What you definitely can make up in this case is Bouchard's nodes, which are going to be related to the proximal interphalangeal joint, and Hibbert's nodes, which are related to the distal interphalangeal joint. Now, what I say next has to be listened with a lot of care. There's a distinct possibility that in this old lady or man with osteoarthritis, at the area where the Hibbert's nodes are, there could be a development of redness appearing, and maybe by the end of the day, apart from this redness, there could also be a yellow point that could be appearing bang in the middle, which to a non-medical will look like pus, but that is again a presentation of acute gout. You see here in this case, I've tried to highlight that it may not be that tophi are only gonna be described maybe only to the lower extremities. Tophi could develop in, the word is tophi can develop even in Hibbert's nodes. Tophi could be developing even with respect to Bouchard's nodes. Normally when I describe any disease to you, I say that that is the diagnosis, but here I'm saying it could coexist. You see, in old age, multiple other diseases are coexisting. No, this is an old man or a woman. They are having hypertension. They are on diuretics. They are having osteoarthritis changes in their hands also. So gout can actually coexist in old age with multiple disorders as well. Now, since I'm talking about a chronic presentation, no big deal that even the kidneys of these patients can be involved, and you could have a possibility of kidney stones. So I just have to write the word nephrolithiasis. Let us just recall what are the clinical features that you can be encountering in a patient who would be having acute gout, and there is a pre-existing hyperuricemia in this person as well. The only thing is at the moment it was flare up of the disease. I said it could be person waking up bang in the middle of the night with excruciating pain mimicking cellulitis. They could be tophi, that is deposition of monosodium urate crystals in the following areas, that is in the earlobe, in the hands, pre-existing Bouchard's nodes and Hibbert's nodes, and yes, they could be nephrolithiasis possibility as well. Now we will focus on what is the best test to confirm the diagnosis of this disease. Most guys casually answer uric acid levels. I want to tell you that in acute gout, the uric acid levels may not be elevated in the blood. During an episode of acute gout, there is a distinct possibility that uric acid levels in the blood might be normal or even less than normal. Why? Because all the uric acid is mobilized into the joint space. So there's a synovial inflammation. It is uric acid which is elevated in the joint space. Therefore, the investigational choice for diagnosis of acute gout, as you have worked out right now, is not serum uric acid but is a joint aspiration. Once we do the joint aspiration, we will evaluate the synovial fluid under a microscope. That's the standard one, and then a polarized microscope. The synovial fluid under a standard microscopy will be revealing increase in the amount of cells. Here you guys should be knowing, do we have cells in synovial fluid? Like I asked in CSF, no, do you have cells in CSF? Answer is yes, 0 to 4 lymphocytes. Similarly, do you have cells in the synovial fluid? The answer is yes. Less than how much? Less than 200 cells usually. But whenever there's an inflammatory state, the cells will obviously increase. Normally they're gonna be lymphocytes, but now neutrophils will come in. So how many cells can be present here? They can be up to 10 times the normal. I said normal would be less than 200. Here they could be 2000. They could be going up to 6000. So when you read about 2000 to 6000 cells per cubic millimeter, and this is not an absolute figure, this is a usual range that you see. It can obviously be higher, and sometimes the fluid that will come out may be turbid, and sometimes it might be chalky white also. Well, lots of time when he will write this finding of turbid fluid in the synovial fluid aspiration, you might get an impression that he's talking about some kind of septic arthritis. But yes, I mean, in septic arthritis, I will then prepare a gram stain, I'll do a culture, and I'll be able to isolate the organism. In this case, it is monosodium urate crystals that are triggering an extreme inflammatory response. Now comes the key word of the MCQ, that is, he will examine the synovial fluid aspirate under polarized microscopy. And that is where the key word will be written, negatively birefringent crystals, that will be needle shaped. I also want to highlight the fact that this word has to be read very carefully. Needle shaped crystals in joint fluid aspiration which are negatively birefringent under a polarized microscope. Now see how he will play the trick on your mind. And listen to these words very carefully, because when this question came, one of my very brilliant students secured a very good rank. He just picked it up. He said, "Sir, I was reading the question. I was thinking, is he asking about gout? Gout is such a simple disorder." And then I realized that he was not asking about gout. The question was framed very beautifully. He gave a description of a person having joint pain. He did not specify only the big toe involvement. He said the person is having joint pain and a joint aspiration was done. And when this was examined under electron microscopy, then the doctor could actually evaluate needle shaped crystals. He said, "Sir, I read the question twice because it was written needle shaped crystals on electron microscopy, and you had told in the class that you see under polarized microscope we get needle shaped crystals." So he says, "I applied the power of exclusion, and that is what you need to develop, guys. I mean, most of the questions in the exam, you would be solving them on exclusion because all of them are new questions, no? So the point is that the faster you try to do questions and the more you try to practice, you will develop that skill, that uncanny skill to get your eyes to the right answer. And that obviously takes time, practice, and lots of patience. So he said, "Sir, the question was needle shaped crystals on electron microscopy." So I ruled out the answer as gout, which everybody else answered. And yes, he got to the right answer. That's going to be calcium hepatite. So we need to just keep our all senses tuned to the perfect optimal level. I mean, my message here is loud and clear. It should be like this: whether you have eaten food, you have not eaten food, whether you are thirsty, you are not thirsty, whether you have not slept the whole night one day before the exam, you are not slept 2 nights before the exam, does not matter. Your performance in MCQ should not be affected by anything, guys. Whether it is emotional trauma, you had a fight with your girlfriend, you had a fight with your mom, you had fight with anybody, everybody, does not matter. You did a night duty the night before, still your MCQ performance on the day of the exam has to be spot on, and that requires a lot of dedication, guys, lots of effort. So that is why I would like you to listen to this data of mine repeatedly so that it gets imprinted in your brain. As I have highlighted, doctors are supposed to have a photographic memory. So do remember these two statements. The statements are needle shaped crystals on polarized microscopy. Negative birefringent word may or may not be given in the question. On polarized microscopy, that's gonna be when you will answer gout. Otherwise, the answer would be based on what I have just highlighted, because he said electron microscopy. So let me just summarize the investigation part before you. I have already told you that I'll be doing a joint aspiration, evaluating it under a microscope, including polarized microscopy. I need to do some additional tests as well. Obviously, I need to do a serum uric acid levels, no doubt about it. But I would also like to do in this patient a 24-hour urinary uric acid levels. Now, why do I want to do this test is because I want to diagnose whether this guy is a overproducer of uric acid or is he a under excreter. Because when we talk about hypouricemic therapy, you see, if somebody is an overproducer, I need to put on the brakes to reduce the production. If it's an under excreter, I need to give drugs to increase the excretion via the kidney. So the treatment approach will vary on a long-term basis. Acute attack can obviously be managed with indomethacin, ice packs, not a big deal. It is hypouricemic therapy that is of paramount importance for management of this person, because I want to prevent such a flare-up. I want to prevent such a manifestation from developing again in the person. So yes, I'm just writing for the sake of completion. Serum uric acid levels, as I highlighted, they can even be normal during an acute attack. Yes, in chronic gout, they're always elevated, but in acute gout, the values can be falsely normal, falsely because all the uric acid is mobilized into the joint space. Then I will do a standard urine microscopic examination, because anyway, he's having possibility of kidney stones as well. I would also like to do a KFT in this guy, because lots of hypouricemic therapy drugs like allopurinol needs a dose adjustment. If somebody had kidney stones, did not take treatment, then kidney would be damaged, serum creatinine may be elevated. And therefore, you will have to modify the dose of standard drugs. I will talk about all the hypouricemic drugs in my subsequent slides, but here I just want you to remember that most of these drugs and lots of these drugs may be actually excreted via the kidney. So dose adjustment is required for especially drugs that lower the elevated uric acid levels in patients of chronic gout. Now, having said that, I also want to do a lipid profile and even a LFT, because when I'm talking about old man or an old woman, they could be having concomitant atherosclerosis as well. So it's always a good idea to do a lipid profile. Also, I want to evaluate for possibility of non-alcoholic fatty liver disease. See, I am trying to point you to the fact that we have discussed in cardiology a disease by the name of syndrome X. Syndrome X would be that the person's abdominal circumference will increase, he will develop centripetal obesity, he will become hypertensive. Along with that, he will have hyperlipidemia. There would be impaired glucose tolerance. So you need to treat the person as a whole. I mean, I'll not just treat only the gout component. I need to treat the syndrome X manifestations as well. So concomitant medical disorder, which could be coexistent in this person, also has to be handled. The subsequent test that I'm telling you is only for academic reasons, X-ray findings and ultrasound findings during an acute attack. Well, most of the time X-ray is going to be normal, though sometimes if I zoom in, you definitely will be able to evaluate this soft tissue swellings, which is very, very, in your face, you can notice the swelling that is coming at the first metatarsophalangeal joint. Along with that, you will also notice, and I'll just use a finer pointer now, and I'll zoom in the image also, you will notice some erosive lesions present, right? Because this guy is a patient of acute and chronic gout, and he has had many flare-ups of the disease earlier. Because he's had recurrent flare-ups of the disease, therefore there is some lytic lesions which could be present with respect to the metatarsophalangeal joint. So you're going to read a MCQ that will say the word Martel sign. Well, Martel sign can also be written as rat bite margin lesion that might be encountered. You see, it looks like a erosive lesion present here. As I've highlighted, rheumatoid is erosive, gout is erosive. On the other hand, rheumatic and SLE are primarily examples of non-erosive. Erosions can occur even in SLE only, but fundamentally speaking, in SLE, if you would answer that as a single best response as an example of non-erosive arthritis. Martel sign is rarely to be seen because most of the time you hardly would get an X-ray of a person of gout and you would start treating the patient right away. Most physicians, when they see a patient of acute gout, they are not gonna run these tests because investigations can be done later. Treatment is of paramount importance because if somebody is having severe pain in the joint or special pain in the foot, he can't even walk properly. He'll walk with a limp or walk with support. So I need to reduce the inflammation spot on. If I do a ultrasound of the swollen joint in this case, I might be having this finding called as double contour sign. 7 and 8 are purely academic aspects, otherwise nobody would be bothering to get these done actually in patients. And let's now look at what are you going to do for these patients so that this swelling in the big toe goes down. In fact, another image that I can highlight at the moment is you can see the swelling related to the knee joint. No, it's all red, it is inflamed. So, well, what is the lesion present here? You want to call it a tophi. As I've highlighted, tophi may not only be present in the lower extremities, there's a distinct possibility that they might be present in the hands. They might sometimes in the later part of the illness even develop a yellowness in the middle, which patient will say pus, but that's the inflammatory component. And at the same time, even earlobes can be involved. Let us now look at what am I going to do for the management of this flare up. Well, the primary step that I'm going to use is ice packs and indomethacin. Always tell a person whenever there is inflammation present, always tell a patient when there is a lot of swelling present not to use a hot pack. As in India, people tend to use a hot pack. Hot pack will cause vasodilation, the pain component will increase. So it is a combination of ice packs and COX-1 inhibitors like indomethacin or naproxen which can be used in the patient. I have spoken about these drugs even for management of a person having a migraine attack. So highly effective, though they can cause a gastritis component also. Now, lots of time people might be having hypersensitivity to painkillers. Like this person says that whenever I use indomethacin, I start getting swelling of my lips, or I get breathing difficulty, or I get beehives, or I get a rash all over the body. So I'm describing a person who's having intolerance to COX-1 inhibitors. Well, what are you gonna do? You might try out a COX-2 inhibitor, but the point is, the efficacy may not be that good. So you can definitely use steroids. When I taught rheumatoid arthritis to you, I was discrediting, I was criticizing steroids. I was saying don't give intra-articular or oral steroids to rheumatoid arthritis because they don't alter the disease process. But here in acute gout scenario, he says that you definitely can use steroids, especially in a person who is having hypersensitivity to the standard painkillers. These steroids can either be given orally or in some cases you can even use it intra-articularly because you see steroids are after all anti-inflammatory agents, no? So they'll cut down on the inflammation part. So indomethacin or steroids can be used or can be used in combination also by some physicians. Don't be in a hurry to introduce colchicine. Yes, you will introduce colchicine, but don't be in a rush. Why? Because when you will write colchicine to the patient, you don't need to remember the dose. One of the biggest disadvantages of this drug is development of diarrhea. Now, Imagine somebody is having pain in the foot at the base of the big toe, and he's already walking with a limp, and then your drug causes a diarrhea. You can imagine the amount of hate that your patient will have for you, because if you have ever had diarrhea in your life, you can understand going to the washroom is such a hassle after every 15 minutes. And in this person with pain in the foot and then making him walk and go to the washroom due to the diarrhea component induced by physician, I mean, patient's not going to be happy with you. So colchicine is something that you introduce after 2-3 days once the swelling definitely comes down. So you can use COX-1 inhibitors primarily, you can use steroids. And MCQ wise, remember, we don't give aspirin. You see, the MCQ was which of the following is contraindicated in acute gout. Studies have shown that if you give aspirin in a scenario of acute gout, it can actually cause more precipitation of uric acid crystals in the synovial fluid. It can actually worsen the patient. So aspirin is contraindicated. That's one scenario I wanted to remember. And then the standard drug allopurinol, we use it for chronic gout. If we use an acute gout, it again can cause more crystallization initially. So allopurinol and aspirin are contraindicated in these patients. Once this patient is better, then you can definitely start hypouricemic therapy. The usual query of your patient as well as multiple choice question will be, what is the end point? I mean, till how long do you need to continue with drugs that will lower the uric acid levels in this person? You would tell this person that I would like to give hypouricemic therapy till tophi totally disappear. So that is one which will tell the person that the drugs are to be given for a couple of months. Second, I would tell this guy that once your serum uric acid level touches normal, please listen to the next point very carefully. Once uric acid level turns to be normal, then it has to remain normal for continuous 6 months. Please appreciate, I'm not teaching you that hypouricemic therapy is to be given for 6 months. It has to be longer than that. I am saying the day the values of serum uric acid will touch normal, from that day up to 6 months, the hypouricemic therapy is to continue. For management of this condition, initial steps that I'll tell the person would be to limit the non-vegetarian food that he is eating. So purine intake is substantially to be curtailed, and at the same time control of weight is important. So I'll definitely refer this person over to a dietitian, or there's so many apps available by which a person can know which food items are good or bad for him. If diuretics are being used in the patient, your dosage of diuretic may actually need an adjustment. Now here the usual query I get from most students is that, sir, you were criticizing thiazide group or diuretics initially, so now you're saying that you are not going to stop them and you are just going to do a dose adjustment. See, we don't have to be judgmental. Diuretics could have been introduced in this guy because he was having hypertension followed by heart failure contributing to edema. You see, there could be a possibility that in this particular chap, diuretics were used to mobilize the pedal edema component. So we don't have to be judgmental about the previous physician and think that he gave a wrong prescription. Why a previous physician gave diuretics to a old patient, that is obviously known to the old physician, and now we the patients keep on doing doctor shopping and they keep on criticizing doctors in front of doctors. I want you to appreciate, if it's a hypertensive patient, he's gone into heart failure maybe once acute and then gone into chronic and is having a pedal edema, the physician was right in giving diuretics. The disadvantage is that diuretics would have contributed to a flare up of acute gout, and the patient may not have gone to the same physician again because he thinks that his medicine is causing a side effect. Either you can adjust the dose of diuretics or you can switch over the person to calcium channel blockers. So it has to be done judiciously depending on whether diuretics were really needed or not. The third step that you will do here will depend upon 24-hour urinary uric acid levels, because suppose the values turn out to be elevated, it means the person is a overproducer. On the other hand, if the values turn out to be lesser, that means that the person is an under excreter. So that is why the kidney tubules are not working. So the drug treatment that I'll explain to you next, which will occupy almost half of this slide now, is gonna be based on 24-hour urinary uric acid values. Under excretors, one of the standard drugs that we give is probenecid, and for overproducers, the standard drug that we shall be giving is allopurinol. Well, no issues with that. We also need to remember some of the newer drugs which are used here. For under excretor, where the 24-hour urinary uric acid level is low, probenecid will enhance the excretion of uric acid. On the other hand, allopurinol will put on the brakes by inhibiting the synthesis of uric acid. Now, allopurinol has some very nasty side effects which are asked in the exam, so it's always a good idea to remember them. You can revise your pharmacology here. One of the big side effects of allopurinol that you read is granulomatous hepatitis. It is even notorious enough to cause toxic epidermal necrolysis, where a person can develop blistering or grossly big bullas or blisters all over the body. And if more than 30% of body surface area is involved, then the manifestation, I mean, the toxic epidermal necrolysis is when substantial amount of the body is damaged, or another version of that is called as Steven Johnson syndrome. The differentiation between them, 10% of body surface area, 30%, that you can read from dermatology. But I just want to tell that apart from anti-epilepsy drugs like lamotrigine that can cause Steven Johnson and toxic epidermal necrolysis, even allopurinol is notorious, that though it's rare, but still I said it is notorious to contribute to this blistering disorder. Allopurinol is problematic with patients having a deranged kidney function. So he says that for an overproducer, it is better to use febuxostat. I would like you to remember this statement. This molecule is safer in patients with renal failure. It's not that you can't give allopurinol in patients with renal failure. The dose has to be changed. So he says better to switch over to febuxostat. I also here want to bring to your notice a nasty scenario which will be written as, and I'm highlighting this with a separate color, medically refractory patient. I mean, you have used the standard drugs in the patient. He is a case of chronic gout. His uric acid is permanently elevated, and you have tried all the standard drugs for the left hand side, but still he's not improving. So we have a IV molecule available. I'm very sure you are aware of this from your pharmacology also. So this should be serving as a quick revision, especially the therapeutic part here. Pegloticase can be used, and this will help in the uric acid levels to be brought back to normal. Let's now focus on the underexcretors. Two drugs coming up. One is benzbromine. This molecule has not been given permission in certain countries, is permitted in certain countries. That happens no. Sometimes in Europe a drug is being used, not in America, vice versa. Benzbromine is again safer in patients of chronic kidney disease, but in some countries it has actually been withdrawn. So I'll just highlight, like I taught, that tacrine has been withdrawn due to hepatotoxicity in a discussion of Alzheimer's disease, or I talked about tolcapone being withdrawn for Parkinsonism because of hepatotoxicity. Today I'm talking about benzbromine withdrawn in certain countries due to the hepatotoxicity potential. The word is hepatotoxicity potential. Another drug that is mentioned here is lesinurad. So, well, we have this huge amount of drugs available in hypouricemic therapy, and they have to be taken on a long-term basis. So, you need to be pretty familiar with respect to which of them would require a dose adjustment. When it comes to the crystals part, I want to highlight the fact that whenever you read, though I've told this, I'm highlighting this fact again. Whenever you read about negative birefringence and needle-shaped crystals, I'm writing negative B, that means negative birefringence under polarized microscopy. Actually, you see, if I begin the question by saying negative birefringence, you know the answer. So he'll begin the question by saying needle-shaped crystals. And we are talking about at the moment the joint aspirate component. So it is monosodium urate. Instead of writing uric acid, they write MSU, that is monosodium urate. I've just explained to you that if it is gonna be no mention of polarized microscopy, only electron microscopy, then the answer would change, and this would be calcium apatite. Now listen to my next statement very carefully. I am talking about crystals which are weakly positive birefringent. The word positive B here means positive birefringence, and the weakly, I mean, you can neglect the word weakly, but the shape of the crystals in this case is rhomboid rectangular. Well, you would have studied this in pathology or even in surgery as well sometimes, that rhomboid rectangular crystals in joint space which are weakly birefringent positive, that would be calcium pyrophosphate crystals. Yes, you got it right. That is the case of pseudogout. Had I begun the discussion of pseudogout by telling you that the most common joint involved is knee joint and steroids are given, you would have still been able to crack the question, because even the orthopedician talks about this fact that in pseudogout we give steroids. In acute gout, I was saying primarily is COX-1 inhibitor, backup is steroids, but here the primary treatment is steroid, and it is calcium pyrophosphate crystal that I'm talking about. What is the shape? It is rhomboid rectangular, positive birefringent. Two must know informations at the movement. Negative birefringence, you know. Positive birefringence should also be known by you. In contrast, the next one again is a twister. He will say bipyramidal crystals. You see, they love to talk about these shapes that we start imagining in our brain. We doctors are anyway bad at mathematics, no? So all these rhomboid and pyramid, everything might look the same to us. So bipyramidal crystals on a light microscopy, cut. Bipyramidal crystals on a light microscopy, these are going to be encountered with calcium oxalate. Please remember that I have taught you that in the urine, if there are calcium oxalate crystals present, they would be envelope shaped. So at the moment, this discussion is well for synovial fluid per se. Let's just quickly remember the facts here with respect to synovial fluid. There are actually only 4 points worth remembering, though there's a lot of data given in the textbook. It's just four aspects to be remembered. One, the question of needle shape that I've highlighted only twice to you. So I think that's imprinted in your memory. Rhomboid, rectangular, and bipyramidal crystals are the additional aspects which you just have to get the orientation right. So these are the questions that you need to basically get your orientation right. Another question having overlap with even forensic medicine where they talk about saccharine gout. This is going to be associated with lead poisoning. You traditionally read about lead poisoning with respect to Boltonian line, then basophilic stippling of red blood cells, then you read about urinary ALA, aminolevulinic acid levels elevated. I just added an additional fact: lead poisoning can contribute to saccharine gout. When it comes to joint aspiration findings, which are encountered most of the time, I would like to finish this discussion by telling you regarding the normal findings that we see with respect to synovial fluid aspiration. Well, the fluid is going to be colorless and translucent with a high viscosity. The viscosity component would ensure that there is minimal friction during the movement of our joints. The cell counts have already been told to you that is less than 200, but if you find them grossly elevated, it could be inflammatory process, it could be a septic process. I also want to draw your attention to this particular finding, viscosity of the synovial fluid. If you read a question where the viscosity is reduced, it's always going to be indicative of inflammatory process or a septic process, because you see, remembering the number of cell count per se is a hassle. No, if I say 2000 to 50,000, if I say more than 50,000, you will say, sir, already in CSF you were telling mathematical data to be remembered, now you expect us to remember data for synovial fluid also. So I want you to remember that yes, cells are increased in inflammatory process, obvious, but along with that, suppose you see from the cells component you are little bit in a fix, then this finding that I just highlighted, viscosity is relatively reduced in inflammatory or septic process, will also do you good. I repeat the fact that normally less than 25% neutrophils could be present in the synovial fluid. Only when the counts are higher and gram stain is positive, culture is positive, can you say the word septic arthritis. So this is just a synovial fluid aspiration based table that I have compiled here before you, and the details are very straightforward. The main focus was to explain to you regarding acute versus chronic gout and correlate that with pseudo gout where knee joint is involved. And even if he mixes and matches the data, you should be able to focus on the core issues that I've highlighted. Like for the treatment part, they would love to exploit your knowledge of pharmacology. They'll play around with the crystals component. But if you just listen to this discussion once again now at maybe 2x today, right now, or maybe tomorrow morning, then you would be able to imprint more data into your brain. And as I highlight, I'm going to do that again on a regular basis. Guys, knowledge is power, and that is the only power that we doctors actually need to exercise, because the way you talk with your patients, the way you interact with your patients, your confidence level is directly proportional to the kind of knowledge that you have. Thank you so much for hearing me out.